السلام عليكم بسم الله الرحمن الرحيم. First of all, we have an introduction. Hematological disorder in the fetus and the newborn infant arise from the conditions which primarily affect blood constituents such as red blood cells, hemoglobin, and platelets. Some of the conditions are inherited and are detected by prenatal diagnosis or screening at birth. Symptoms in affected infants may start either in utero or after birth. Diagnosis of some of the hematological conditions may be complex, requiring interpretations by a pediatric hematologist. Treatment includes prevention and specific therapies. It should be borne in mind that the normal hematological indices in newborns are different from those in older children and vary according to postnatal age. Causes of neonatal anemia. First of all, we have physiological anemia, anemia of prematurity, hemorrhage like antepartum hemorrhage, fetal-maternal transfusion, twin-to-twin transfusion, neonatal internal hemorrhage. We have also hemolysis, aplasia like Blackfan diamond syndrome. We will discuss some of our topics like placental transfusion, the blood volume and red cell in mass at birth and in the neonatal period depend on the volume of the placental transfusion and subsequent readjustment of blood volume. This occurs within 3 minutes of delivery and can contribute up to 25% of the total neonatal blood volume. This amount will be increased in the following situation: elevated maternal blood pressure, use of oxytocin drugs, late clampings or milking of the cord, infant held in a low dependent position at birth. On the other hand, the amount will be reduced by early cord clamping or holding the infant above the level of the attached placenta. The average blood volume of the newborn infant is 85 to 90 milliliter per kg. The practice of delaying clamping the umbilical cord or milking the cord from the placenta to the baby may have both advantages and disadvantages. Although this can result in improved blood volume and reduced iron deficiency in childhood, there may be associated disadvantages too, as an high red cell mass can result in symptomatic pulmonary pleurisy and hyperbilirubinemia. This subject of early versus late physiological clamping of umbilical cord is still a matter of debate. In the UK, Resuscitation Council recommends delaying cord clamping for 1 minute in uncompromised babies. What about physiological anemia? The full-term infant is born with a hemoglobin concentration in the range of 15 to 23.5 gram per deciliter. In the preterm infant, the hemoglobin level is slightly lower. Initially, there is a slight increase due to hemoconcentration, but then hemoglobin gradually drops and remains low for most of the first year of life. This is known as physiological anemia. Anemia of prematurity. In the preterm infant, physiological anemia occurs earlier, is more severe and prolonged than in the term infant, and is termed anemia of prematurity. It is caused by a number of factors: lack of erythropoietin at birth. The infant moves from a relatively hypoxic fetal state to become relatively hyperoic. This suppresses erythropoietin secretion for the first 7 to 8 weeks of life. In addition, the bone marrow is probably more resistant to the stimulatory effect of erythropoietin. When this ends, reticulocytes starts appearing in the peripheral blood film. Repeated blood sampling. The preterm infant is often subjected to daily repeated blood sampling for laboratory investigation. This is the commonest cause of anemia in babies admitted to the neonatal units. Relative hemodilution. There is an increase in plasma volume over the first months of life, and together with poor red cell production, the hemoglobin falls. This is referred as early anemia. What about iron deficiency? The full-term infant is born with sufficient iron stores for the first 4 months of life, but in preterm infants these stores are low and exhausted more quickly because of the infant's rapid growth rate. An infant of 1.5 kg at birth has half the iron stores of an 3 kg neonate. Iron deficiency mostly causes the late anemia that accounts for low hemoglobin levels after 4 months of age, characterized by hypochromic red cell seen on blood film. What about hemolysis? Hemolysis may occur in preterm infants as a result of vitamin E deficiency. As such, administration of vitamin E may reduce the extent of late anemia or prematurity, but this is not used in practice. Causes of hemorrhage. We have hemorrhage before and during delivery from placenta, like placenta previa, placental abruption, incision into the placenta during cesarean section, from the fetus, feto-maternal or twin-twin transfusion, from the cord, rupture or torn vessels on insertion into the placenta. From the neonate himself, neonatal hemorrhage like trauma, bleeding may occur into the skull, brain, lung, peritoneum, or bowel. Otherwise, we have hemorrhagic disease of the newborn. Investigation to determine the cause of hemorrhage. There will depend on the provisional diagnosis and include hemoglobin and hematocrit, assess the presence of fetal cell in maternal blood indicating feto-maternal transfusion, coagulation studies, investigations to determine site of bleeding like ultrasound, CT, MRI of head and or abdomen. We have also causes of immune and non-immune neonatal hemolysis. Rhesus incompatibility, ABO incompatibility, minor blood group incompatibility, maternal autoimmune disease like SLE, non-immune hemolysis, negative comp test like congenital infections, DIC, G6PD deficiency, pyruvate kinase deficiency, hereditary spherocytosis, alpha thalassemia, infantile pinocytosis, vitamin E deficiency. Here we have some complications of rhesus or severe ABO incompatibility. The complications include kernicterus and bilirubin encephalopathy, hyaline membrane disease, beta cell hyperplasia of the pancreas resulting in hypoglycemia, hypoalbuminemia and lung edema, thrombocytopenia and DIC, complications of exchange transfusion, anemia. Anemia results from ongoing hemolysis and require monitoring the checking hemoglobin level and restricted count. Treatment include of anemia. Treatment include folic acid administration and top-up transfusion iron therapy. Here we have another cause of anemia like glucose 6-phosphate dehydrogenase deficiency, which causes hemolysis. This disease is inherited in an X-linked recessive manner and is due to a deficiency of the enzyme glucose 6-phosphate dehydrogenase within the RBCs. Therapy rendering the cells more susceptible to hemolysis. More than 100 million people throughout the world, mainly Chinese, South Mediterranean, Black Americans, or Black Africans, have this abnormality. It usually occurs in males, although the heterozygote female may manifest mild features of the disease. There are many variants of this condition, some requiring an oxidizing agent to trigger hemolysis and others that cause hemolysis spontaneously. Some infants with the enzyme deficiency develop jaundice in the newborn period without exposure to oxidant drug, but in other variants of the condition, oxidant drugs are required to trigger the hemolysis. In later years, otherwise healthy children may become acutely ill with anemia when exposed to drugs. Some drugs may cause hemolysis in infants with G6PD deficiency, like anti-malarial drugs like nitrofurantoin, sulfonamide, phenacetin, aspirin, acetylsalicylic acids like nadilsic acids, methylene blue, naphthalene, vitamin K, and chloramphenicol. What about pyruvate kinase deficiency? This is an autosomal recessive condition affecting glucose metabolism within the red cell membrane. Spontaneous hemolysis occurs in the neonatal period with anemia and jaundice. Splenomegaly is always present. Diagnosis is made by enzyme assay. What about hereditary spherocytosis? Hereditary spherocytosis is an autosomal dominant condition that may cause neonatal hemolysis. The blood film shows spherocytosis with little splenomegaly initially. A family history of hereditary spherocytosis is an important diagnostic point. The spherocytosis shows an increased osmotic fragility, although this may not be apparent in the first few months of life. Severe hemolysis with very high levels of hyperbilirubinemia may occur suddenly. What about thalassemia? Classic beta thalassemia major does not affect neonates because most of the hemoglobin is in the fetal hemoglobin F form. Alpha thalassemia is a rare and severe condition that causes high drops and severe anemia. He have a diagram to summarize the workup to diagnose a case of neonatal anemia. First of all, there is a decrease in the hemoglobin concentration. We have to perform reticulocytic count with low reticulocytic count. Congenital hypoplastic anemia should be considered. Normal or high reticulocytic count, we have to do COMS test. If it is positive, we have to think about immune hemolytic anemia like ABO, RH, or minor blood group incompatibility. If we have a negative COMS test, we should look for the mean corpuscular volume. If it is low, consider chronic intrauterine blood loss or alpha thalassemia syndromes. If it is normal or high, consider peripheral blood smear. Abnormal blood smear like hereditary spherocytosis, elliptocytosis, pyruvate kinase deficiency, G6PD deficiency, and DIC. If we have normal blood smear, we consider infection, blood loss like sampling, require frequent sampling, fetal-maternal or fetal-placental transfusion, twin transfusion syndrome, internal hemorrhage, rare miscellaneous causes like hexokinase deficiency. This diagram shows the causes of neonatal anemia. We have on the left side physiological contributors to the anemia of prematurity, and we have on the right side non-physiological contributors to anemia of neonatal period. Pathophysiology of anemia of prematurity. We have summarized the causes in this diagram. Also, we have the diagram to show the RH incompatibility and how it proceeds to cause hemolysis. If we have a mother with an RH group, RH negative group, and a father with an RH positive, which is more dominant, we have a mixing of blood during the first pregnancy. Mother becomes sensitized, it will produce anti-RH antibodies in the maternal blood, which will cross the placental barrier and react with the fetal RBCs. It will cause hemolysis and hemolytic disease of newborn. Thank you for our lecture.